Well, the next topic is bile, with its around 600 to 1000 milliliters per day production. Here is the composition of bile, which consists of water, inorganic salts, bile salts, pigments, and lipids, as you can see here on the screen. Now, there are, you can say, 3 to 4 major functions of the bile, which include fatty acid metabolism, excretion of waste products, then it kills off bad microbes, and the functions of bile, they also include blood sugar metabolism through the role of bile acids as signaling molecules in glucose metabolism. What you should memorize is that there are two basic functions of bile. It plays main role in fat digestion and absorption because of bile salts, and then it serves as a mean for excretion of waste products like bilirubin and excess cholesterol from blood. Other functions are achieved by alkalinity of bile, which help in neutralizing acidity of chyme, and the excretion of bile pigments, heavy metals, toxins, cholesterol, and lecithin. Let's now look into the functions of bile due to bile salts. These bile salts emulsify fat globules and help in the digestion and absorption of fats. Bile salts stimulate the secretion of bile from liver, and this function is called cholinergic action, while cholagogue action is the increased release of bile from gallbladder by stimulating the secretion of cholecystokinin. Keep in mind that bile salts, they act as laxatives by causing CCK release and enhancing motility. Let's now have an overview of biliary transport. Here you can see that how bile is formed and then conducted. And this flow chart is very important.
Let's now have an overview of biliary transport. You see, bile is secreted by hepatocytes, and it contains large quantities of bile acids, bile pigments, cholesterol, lecithin, and fatty acids. And bile from the hepatocytes is secreted into biliary canaliculi.
Here again, you can see this flow chart of bile formation and conduction. Once bile is secreted by hepatocytes, it is drained into the bile canaliculi, which terminate into bile duct, and this bile duct then join the hepatic duct and forms common bile duct. Now, bile from this common bile duct, either it goes directly to duodenum or it goes to the gallbladder through the cystic duct. Well, do you know the physiologic anatomy of biliary excretion? You see, bile is excreted in two stages. First is the excretion of initial bile, which is parenchymal excretion, and then there is addition of a second excretion, which basically is the ductal excretion. Initial bile is excreted from hepatocytes into bile canaliculi, which flows toward bile ducts, finally reaching into duodenum or gallbladder. In its course through bile ducts, second portion of liver secretion is added to the initial. Initial bile, it contains large amounts of bile acids, cholesterol, and some other organic constituents. While the additional excretion, it is watery solution of sodium and bicarbonate, which is stimulated by secretin. And this additional excretion can increase the total quantity of bile as much as 100%. Here, the role of secretin is interesting in controlling bile excretion. Secretin may increase bile secretion, sometimes doubling it after a meal. This increase consists of rich watery solution of sodium bicarbonate by the epithelial cells of bile ductules. And this bicarbonate, it helps in neutralizing the hydrochloric acid from stomach. Let's see now that how bile is stored. As you already know that bile is secreted continually by liver cells.
So, bile is stored in gallbladder until it is needed in duodenum. Our gallbladder can hold 30 to 60 milliliters of bile, where this bile is concentrated five folds and it can be condensed up to 20 folds. Keep in mind that our gallbladder, it is not a passive reservoir of bile. It absorbs, excretes and alters the constituents of bile.
But let's see now that how the bile is concentrated in gallbladder. You see, water, sodium, chloride, and other electrolytes like bicarbonates, they are absorbed from gallbladder mucosa. Absorption is caused by active transport of sodium through epithelium. This transport is followed by secondary absorption of chloride, water, and others. So, bile is concentrated, which contains bile salts, cholesterol, lecithin, and bilirubin. Let's now look at liver's excretion of cholesterol. Bile salts are formed in hepatic cells from cholesterol in blood plasma. In the process of excreting bile salts, 1 to 2 grams of cholesterol are removed from blood plasma and it is excreted into the bile each day. Amount of cholesterol in bile is determined by the quantity of fat that a person eats. Well, the description of bile takes me to gallstones also. Uh, so first we will see that how the gallstones are formed. You see that cholesterol is insoluble in pure water. So, bile salts and lecithin in bile combine with cholesterol and they form a colloidal solution in gallbladder. But under abnormal conditions, when there is excessive absorption of water by active sodium transport and passive water absorption from chronically inflamed gallbladder mucosa, and when there is excessive absorption of bile salts from the gallbladder epithelium, then in that case the cholesterol is left behind, which begins to precipitate. First, small crystals of cholesterol are formed, which progress to gallstones. Gallstones could have a calcium nature also, which normally is prevented by acidifying gallbladder bile through the excretion of hydrogen ion from the gallbladder mucosa. Now, here is the list of functions of gallbladder, which include, as you can see, the storage of bile, mucosal absorption. Then there is a concentration of bile constituents, also the maintenance of pressure in biliary system. Excretion of mucin is a function of gallbladder, along with the alteration of the pH of bile. You see, storage of bile, it is necessary because bile is continuously formed and released by the hepatocytes, but this is not continuously utilized. So it is released from gallbladder intermittently when required. Mucosa of gallbladder, it absorbs water, sodium, chloride, and other electrolytes from bile. While the gallbladder itself, it concentrates bile salts, cholesterol, lecithin, and the bilirubin in bile. Now, due to the concentrating capacity, gallbladder maintains a pressure of 7 centimeters of water in the biliary system. And this pressure is essential for the release of bile into intestine. Then you see mucin is added to bile when bile is released into intestine, which acts as lubricant for the movement of chyme in intestine. pH of bile is decreased from the usual 8 to 8.6. to 7 to 7.6. So we can say that it becomes less alkaline when it is stored in gallbladder. Now we move on to the topic of the emptying of gallbladder. You see, the emptying of gallbladder, it requires the contraction of gallbladder and the relaxation of sphincter of Oddi. So, which two things you should keep in mind, that the emptying, it requires two factors. First of all, there should be contraction of the gallbladder, and secondly, there is relaxation of the sphincter of Oddi. Well, the causes for the contraction of gallbladder, they include mainly cholecystokinin, while vagal stimulation, it also has a weak effect in this case. The second factor for the emptying, that is relaxation of sphincter of Oddi, which is caused again mainly by cholecystokinin, but this relaxation can also be neurogenic through the vagus nerve, or it could be a receptive relaxation during peristalsis. Well, so now you know the whole process, that how an acidic or fatty chyme which enters the duodenum, it causes the release of cholecystokinin and secretin from the duodenal walls, enteroendocrine cells. And then this cholecystokinin and secretin, it enters the bloodstream. Bile salts and secretin, they are transported via bloodstream, and they stimulate the liver to produce bile more rapidly. Now, the vagal stimulation, that also causes weak contraction of gallbladder, while cholecystokinin, which is coming via bloodstream, it causes the gallbladder to contract and hepatopancreatic sphincter to relax. So the bile, it enters the duodenum. So that is the whole cycle. You should know that how important bile salts are. Liver cells synthesize about 6 grams of bile salts daily, and the precursor of bile salts is cholesterol. While the source of cholesterol is mainly diet, but it is also synthesized in liver cells during the course of fat metabolism. So, how the bile salts are formed? You see, first, cholesterol brings about the formation of bile acids as the end products of cholesterol catabolism, and then the conjugation of bile acids that results in the formation of bile salts. As you can see in this slide, mm, for the formation of bile salts, Cholesterol is first converted into the bile acids like cholic acid and chenodeoxycholic acid in about equal quantities. And then these acids they combine with the glycine and taurine to form conjugated bile acids. And salts of these acids are then excreted in bile as sodium glycolate and sodium taurocolate. Well, this is quite an important topic. The functions of bile salts, which include the emulsification of fats and micelle formation. I repeat again that this is an important topic, and the two main functions of bile salts these are the emulsification of fats and micelle formation. So, how the emulsification of fats is achieved? In fact, bile salts and the agitation by the gastrointestinal tract it breaks the fat globules to smaller sizes. This emulsification it is also called the detergent function of bile salts, which decreases the surface tension of particles and it allows the agitation in the intestinal tract to break the fat globules into minute sizes. Well, micelles, they are small physical complexes of lipid molecules that arrange themselves in a spherical form in aqueous solution. These micelles, they have amphipathic nature, means they contain both hydrophilic and the hydrophobic regions. And again, our bile salts form micelles of fatty acids, monoglycerides, cholesterols, and other lipids. You see, micelle formation is even more important function of bile salts than emulsification. These micelles, they are semi-soluble in chyme due to the electrical charges of bile salts. And this is how bile salts they carry micelles to intestinal mucosa for absorption. Without bile salts, 40% of the ingested fats they are lost in feces. Now this knowledge it is used in the clinical use of a drug which is called orlistat. This drug binds to lipases in gut and blocks their action. So there is reduced micelle formation due to orlistat induced blockage of triglycerides digestion. Let's now have a look at the recycling of bile salts and the role of enterohepatic circulation in it. In this enterohepatic circulation, 94% of bile salts are absorbed from gut into portal blood and then they are passed to liver, absorbed by hepatocytes through the sinusoids, again excreted into the bile and again reabsorbed. On average, bile salts make an entire circuit 17 times before being excreted in feces. The bile salts, which are reabsorbed from gut, one half are absorbed by diffusion through the mucosa in early portion of small intestine, while the remainder is absorbed by active transport process through the mucosa of distal ileum. You must keep in mind that enterohepatic circulation is significant. Quantity of bile secreted each day is highly dependent on the availability of bile salts. It means greater the quantity of bile salts in the enterohepatic circulation, and there will be greater the rate of bile secretion. Usually, a total amount of bile salts in circulation is around 2.5 grams, and for 1.1 gram per deciliter bile salt secretion for liver. Now let's move on to bilirubin. You see, many waste substances are excreted in the bile and eliminated in the feces. One of these is the greenish yellow pigment, which is called bilirubin. Bilirubin is a major end product of hemoglobin degradation, and it helps in diagnosing hemolytic blood diseases and also various types of liver diseases. I'm sure you don't remember the origin and the fate of bilirubin, which was taught you in the first year. So let's briefly revise it. Um, you see, RBCs they rupture after 120 days, and the released hemoglobin, which is phagocytized by tissue macrophages, it splits into globin and heme. Now, the heme ring, this is opened to give two things: free iron, which is stored as ferritin, while the other thing is protoporphyrin 9, which is converted to bilirubin. Initially, biliverdin is formed, but it is immediately reduced to bilirubin. Now, this bilirubin is released from the macrophages into the plasma. It binds to albumin in plasma and absorbed through the hepatic cells. Here it is conjugated with the glucuronic acid to form bilirubin glucuronide and then excreted from the hepatocytes into intestine through bile canaliculi and then into the finally into the intestines. Into the intestines, it is converted to urobilinogen by the action of bacteria, but it becomes urobilin in urine while stercobilin in feces. Here is the flow chart, which is explaining the same mechanism or process I already told you, and carefully look that how the urobilinogen it becomes urobilin in urine while it is stercobilin in feces. And the hepatocytes, they help in the conjugation to form the bilirubin glucuronide when this binds with the glucuronic acid. Here you can see the differences between unconjugated bilirubin and the conjugated bilirubin. You can see that the unconjugated one, that is normally present in plasma, while the conjugated bilirubin is present in bile. And this could be a viva question also, so please memorize these differences. Let's now have a look at bilirubin's relation to jaundice. Jaundice, as you know, is the yellowish tint to the body tissues. In jaundice, large quantities of bilirubin, they are present in the extracellular fluids, either the free bilirubin or the conjugated bilirubin. Keep in mind that its normal plasma concentration is around half a milligram per deciliter, but it becomes detectable clinically when the plasma bilirubin it exceeds 1.5 milligram per deciliter. Even in abnormal conditions, it can rise to 40 milligram per deciliter, which is very high. So, what could be the causes of jaundice? Memorize it that the causes of jaundice, they could either it could either be the excessive hemolysis, or there could be obstruction to the bile outflow from the liver. In hemolytic type of jaundice, there is increased destruction of red blood cells with the rapid release of bilirubin into the blood. Now, this excess bilirubin, it is actually beyond the conjugating ability of the liver. So, the excess bilirubin is in the unconjugated form. The other type is the obstructive jaundice. In obstructive jaundice, the obstruction of the bile duct, it could be due to stones or damage to the liver cells due to cancer. Now, what happens that the bilirubin is normally conjugated, but it cannot be excreted into the intestine due to the obstruction. And do not forget that this bilirubin formed, that is conjugated one. So the main mechanisms which produce jaundice, they are increased production of bilirubin or impaired excretion of bilirubin. And based on this basic mechanism, there are three types of jaundice. The prehepatic one, which is called hemolytic jaundice, and then there is hepatic and posthepatic. The hepatic one is called hepatocellular jaundice, while cholestatic jaundice is the form of posthepatic jaundice. Hemolytic jaundice, which is, as I already told you, that it is also known as the prehepatic jaundice. That is due to increased destruction of red blood cells or their precursors in the bone marrow in conditions like anemia, malaria, or the neonatal jaundice, or in case of transfusion reactions and autoimmune diseases. This type of jaundice, it was previously known as acaloric jaundice because of no bile pigments in urine and excessive unconjugated bilirubin in the circulating blood. Now, clinical features of hemolytic jaundice are pallor of skin, splenomegaly, which is the enlargement of spleen. Then the color of stool could be normal or dark, while the urine is always dark colored because of increased urobilin. On investigations of hemolytic jaundice, plasma bilirubin level is of course high, and it could be as high as 6 milligram per deciliter. Hyperbilirubinemia, this is of unconjugated type in hemolytic jaundice. Urobilinogen, that is increased in urine. But keep in mind that there is no bilirubin urea in case of hemolytic jaundice, and liver function tests are otherwise normal. Now, the hepatocellular jaundice, this one results from the inability of liver to transport bilirubin into bile as a consequence of parenchymal liver disease, such as the congenital diseases like Gilbert syndrome or Crigler-Najjar or Dubin-Johnson syndrome, or there was another syndrome which is called Rotor syndrome, yes. Now, the hepatocellular jaundice, this could be acquired also in case of acute or chronic liver parenchymal disease. So, what happens that in hepatocellular jaundice, both conjugated and unconjugated bilirubin is increased in plasma. But other clinical features and investigations, they vary with the underlying disease. Cholestatic jaundice, it occurs as a result of obstruction of bile flow, for which the causes they include stones in bile ducts, carcinoma of the head of pancreas, or the ampullary carcinoma, cholangiocarcinoma. There could be biliary strictures, drugs, alcohol, or sclerosing cholangitis. Cholestatic jaundice is always accompanied with dark urine and pale stools, actually clay colored stools due to the deficiency of bile salts. And two other signs are steatorrhea and weight loss. Now, Uh, in the cholestatic jaundice, the hyperbilirubinemia is of conjugated type, and here the liver function tests, they are definitely abnormal. So memorize this chart, which will help you in differentiating different types of jaundice. The Vandenberg reaction is a specific test for the identification of increased serum bilirubin levels. Normal serum gives a negative Vandenberg reaction. And I'm hoping that all this detail on the screen, it was brought to your knowledge in your biochem class. You see the principle of the Vandenberg reaction, and then the reagent which is used, and most importantly the uh, result. You see, the Vandenberg reaction, this could be of two types, the direct or indirect. The direct one, it measures the conjugated bilirubin. And here in this case, the result is the purple color which immediately appears. While in case of indirect Vandenberg reaction, that measures total bilirubin, and here it gives purple color only on the addition of alcohol. Well, here is the grim scenario of what does the binge drinking it do to your liver. uh, this acute liver disease, it causes acute or chronic inflammation of liver. This liver cirrhosis, this is a late stage of you can say scarring or the fibrosis of liver, which is caused by many forms of liver diseases and conditions such as hepatitis or chronic alcoholism. But the first sign of cirrhosis, it is jaundice, and survival rate of cirrhosis is around 5 years, but it can vary from 0 to 80%. Well, moving on to the liver function tests, commonly known as LFTs. Well, at a glance, the liver function tests are bilirubin and the uh, AST, ALT levels, which you can see here, their normal ranges, and then there is AST, ALT ratio, which is increased in disease, and then the total proteins and the albumin globulin ratio. This is also kept in consideration. So, before getting into the detail, this is the summary of liver function tests, and it might be helpful. Let's see now that how the liver function tests, they respond to disease. You see, the liver function tests, they will include the determination of total, unconjugated, and conjugated bilirubin. in serum, whose normal ranges you can see here on the screen. The presence of bilirubin in urine, it always indicates a disease, which is as it is seen in hepatic and the post-hepatic jaundice. Estimation of urobilinogen, it means the urobilin in urine and urobilinogen in feces. And keep in mind that urobilinogen is colorless, while the urobilin, it has yellow pigment. Normally, 100 to 250 milligrams of urobilinogen is excreted in feces, which is increased in hemolytic jaundice, while it is decreased in hepatic and post hepatic jaundice. Now, the urinary urobilin, if we talk about the urobilin, normally half to 4 milligram per day of urobilin is excreted in urine. Now, this amount is increased in hemolytic conditions, while there is decreased excretion in the biliary obstruction. Here are the serum transaminases, whose alternative name you can see here. And these serum transaminases, they are always increased in hepatitis, specifically the serum alkaline phosphatase. Now, its level is increased in extrahepatic and intrahepatic biliary obstruction, and it is an early sign of cholestatic liver damage, which is caused by drugs. High values of alkaline phosphatase, they also occur in osteoblastic diseases of bones such as rickets. Now, how do the plasma protein levels they respond? You see, serum albumin level, they are decreased in liver disease, and also there is decreased albumin to globulin ratio. And among the tests of coagulation, keep in mind that the prothrombin time is prolonged. Cholesterol, free or esterified levels of serum, they also help in assessing the liver function, because these are increased in complete obstruction of bile duct. Now, the indicator of the glycogenic function of liver is the intravenous GTT. It is the galactose tolerance test, and it determines the rate of utilization of galactose by liver. So, in liver damage, galactose is metabolized at a slower rate. Around half gram of galactose is given by intravenous injection, which normally disappears in 75 minutes. The second thing is the epinephrine tolerance test. It is the response of liver glycogen to adrenaline for the assessment of metabolic functions of liver. Epinephrine markedly stimulates glycogen breakdown to glucose in liver, which results in an increase in blood glucose levels. In case of tumor, plasma alpha fetoprotein is increased in case of primary hepatoma. Well, the other investigations they include the viral markers, ultrasonography, CT scan, MRI, and liver biopsy. Here are the clinical manifestations of severe liver disease. And this asthenia, it means the loss of strength. Fetor hepaticus is a particular mouth odor found in these patients. And you know what is portal hypertension and ascites. And hepatic encephalopathy is a form of coma, which is because of the hepatic diseases. The symptoms of end stage liver disease they include easy bleeding or easy bruising, persistence persistent or recurring yellowing of the skin and eyes, and intense itching. There could be loss of appetite and nausea, and swelling due to the fluid buildup in abdomen and legs. Here you may find Wilson's disease interesting, in which there is hepatolenticular degeneration. You see, it's a rare genetic disorder in which the excess copper is stored in various body tissues, but particularly the liver, brain, and the corneas of eyes. Here you can see this Kayser-Fleger ring. Now, in Wilson's disease, the symptoms they do not appear until the copper buildup it is in heavy amount, and the symptoms are jaundice, the personality changes like anxiety, psychosis, and also speech and coordination problems. Well, moving on to acute liver failure, which is a rare syndrome, and it is defined by a rapid decline in hepatic function. Acute liver failure, it might be caused by the toxicity of drugs, viral infection, or the vascular problems such as shock. Now, acute liver failure is characterized by jaundice, the coagulopathy with an INR of more than 1.5, and even hepatic encephalopathy in patients with no evidence of prior liver disease. Fortunately, a liver